I think we're going to get started. Hello, everyone. It's great to see you all here. I am Paula Lomas. I'm Senior Director of Clinical Communications at the CF Foundation. I like to tell people I'm a nurse. I'm a long-term CF nurse. I started in this community 1988, so a long time ago, and so I've been able to be part of the greatest story in medicine. And I joined the CF Foundation in 2015, and that's when we started our work in mental health. And in 2016, I was able to speak at VLC with Dr. Bruce Marshall about our plans for mental health. And then for the past 4 years, I've been working with Ginger Birnbaum in facilitating this session, the mental health breakout hot topic session. Ginger is not able to be here today, but we are fortunate in that she does have a welcome for us. She will be setting the stage and letting you know what you're going to hear today, and she will also introduce our guest speaker. So fingers crossed that technology will work, and let's see and hear from Ginger.
Welcome to everyone in the room and also to everyone online. We look forward to sharing this time with you today. My name is Ginger Birnbaum, and I come to you today as a community member representing the Mental Health Advisory Committee. I have 2 children, King, who was diagnosed with CF in 2011, and Emma Virginia, who, as a sibling to someone with CF, is an excellent healthcare advocate. Over the years, our family has been involved with many different aspects of the foundation, but one of my favorite jobs has been co-chairing this very conference years ago. I hope that you're having a great time learning from one another. With an 11 and 14-year-old at home, life is just too fast-paced to break away right now, so thank you for allowing me to join you virtually. I believe that there is no health without mental health. In 2015, I sat at NACFC, our science conference, and learned about the work of an international committee on mental health and cystic fibrosis. That work bore study results that uncovered an alarming rate of depression and anxiety among people with CF and their family caregivers. Due to that discovery, new guidelines were being put forth to make emotional wellness a part of CF care. I knew immediately that I wanted to be a part of this work because although I valued emotional wellness in general, I had come to value it even more in the context of life with CF. Already, I was seeing that it was affecting our family. I felt that it was vital for the foundation to support these efforts. Luckily, I was able to join the Mental Health Advisory Committee. Over the years, we have accomplished a lot, but the work is not done and needs continue to present themselves. With that in mind, a mental health research prioritization survey was done in 2020, where a large group of community members and providers weighed in on what they felt was most important to research within the context of mental health and CF. Top priorities included anxiety, depression, and the effects of mental health conditions on the physical health of people with CF. Community members were more likely to select topics related to side effects, PTSD, grief, and survivor's guilt, while providers were more likely to select substance misuse and disordered eating topics. Work is ongoing to meet these needs within the community. A big thanks to any of you that took the survey and helped to identify these needs. You'll be hearing more about them later. I'm excited for you all to get to hear from local behavioral health clinician and researcher in CF, CJ Bathgate, who will share about the impact of mental health on the CF community and the ways in which the CF Foundation is leveling up their efforts in this area. CJ is a clinical health psychologist and assistant professor of medicine for the adult cystic fibrosis team at National Jewish Health in Denver, Colorado. Her clinical and research focus is using telehealth and other technology-based interventions to improve health and behavior changes on topics such as stress management, anxiety, depression, and sleep. She is a member of the NACFC Psychosocial Planning Committee and a founding member of the CFF's Mental Health Research Working Group. In addition to publishing in scientific journals, she's also been an expert contributor to articles featured on Forbes and CNN. Later, you will also hear from Paula Lomas, who is the Senior Director for Clinical Communications at the CF Foundation and a tremendous advocate for all things mental health and community care. So, take it away, CJ.
Hello, everyone. I'm just curious who in the audience is not from Colorado, just so I can get an idea of, okay, pretty much everybody. Who's from Colorado? Yes. Thank you for coming, everybody. So I wanted to start today with a story, and also hello to the virtual people that are watching this as well. So I want to start with a story touching upon some of the stuff that Ginger was bringing up back in 2015. So in 2015, there was this major international study. So it was survey respondents from the US and 8 European countries. And they looked at the anxiety and depression prevalence rates among persons with CF that were 12 and above. And this is commonly referred to as the TIDE study, which stands for the International Depression Epidemiological Survey, and that's just a mouthful. So when you hear these statistics I'm about to say, you can just associate that with the TIDE study. So what they found was that people with CF were 2 to 3 times more likely to experience anxiety and depression symptoms compared to the general population without CF. When we looked at these elevated symptoms, adults were more likely to experience these symptoms compared to adolescents and teenagers. Mothers were more likely, the caregivers, to experience these elevated symptoms compared to fathers. And adolescents were 2 times more likely to experience elevated symptoms if their caregiver had reported elevated symptoms. So after that big survey came out that rocked the world of CF and mental health, there was an international mental health guideline consensus statement that was put out. And they recommended that centers screen for anxiety and depression at least once a year. And the purpose of doing this is just to make sure people don't fall through the cracks and to be able to provide additional support outside of just physical health care. So in 2016, there was also a call put out by the CF Foundation to implement a mental health coordinator grant. And so those were people like myself, social workers, clinicians that would now be embedded within the CF Care Center to be able to implement these screening guidelines. So as a health psychologist, my expertise is in chronic medical conditions and that intersection between the mind and the body. And so when I first joined the team, I was studying up on everything CF, learning everything I could. And when talking to my colleagues and talking to my patients, I started realizing that anxiety and depression was way more prevalent than I thought. It sort of was, I had this visual of a duck on a pond. You know, if you just ask somebody, hey, how's your mental health doing? People are usually going to respond, oh, it's fine. But when you just ask them a few more questions, like some of the questions we had on the screener, or just dig a little deeper, you realize there's just a lot more going on under the surface. And so I think that brings us to what the topic is for today, which is about how are we leveling up mental health in this community. So first, the question I want to answer is, what are the anxiety and depression prevalence rates? What do they look like in this post-TIDES era? 2, I want to know, are there unique ways that mental health symptoms are actually manifesting in people with CF? What do we as clinicians and researchers have to be aware of? And number 3, what are we actually doing to address all this, specifically at the foundation level? So on the left, you can see those statistics that I just shared with you. 32% elevated anxiety from that TIDE survey, 13 to 29% elevated depression from that survey. The reason for the variability in the depression reports was there were different measures used, and different measures tend to pick up on different symptoms within different chronic medical populations. And so some are more sensitive at picking up depression than others. And so when I started noticing these increased rates, I wanted to know, what can I do as a psychologist on the team to be able to better support people? So in, I think it was 2017, I wrote a grant to the foundation to pilot, which is basically a proof of concept study, a telehealth intervention aimed at better coping with stress. I called it Coping and Learning to Manage Stress with CF, and we call it CALM. So the CALM study was rolled out, and what was really great about that was we were able to show reductions in anxiety and depression, improvements in quality of life, and ability to cope. And I went back to the foundation and I said, can we do a bigger trial? And the reason why researchers do these bigger trials is we want to make sure it's not just the effect of the interventionist, right? It's not just my relationship with the people I work with or something really unique about the people in Denver. So in 2019, I wrote a grant with 2 other sites, Johns Hopkins Medicine and the University of North Carolina. And part of our grant was we needed to show what are these prevalence rates that we're actually seeing. So when I ran the numbers at my center, 52% reported elevated anxiety and or depression symptoms. And that's a lot higher than what the TIDES study showed. And actually that made me feel a lot better in a sense, knowing that my clinical judgment was there, that, something else was going on and this is something that matters that we need to talk about and we need to figure out. When I had the other sites run their numbers, 42% and 45%. So everybody's numbers across the country were actually higher. And keep in mind, this is from a grant application from 2019. So this is before COVID. This is before Trikafta. This is before all of those major changes. So when we think about what's happened over the past few years, chances are these numbers are much different. But I wanted to show you these numbers that kind of reduce all the noise of the stuff that's been going on over the past couple of years. So now that we know that anxiety and depression rates are a bit higher than what the TIDES study showed, that brings me to my second question. Are there unique symptom manifestations that we need to pay attention to as clinicians and researchers when we are assessing people? And so this is not an exhaustive list of all the different things I see. I just pulled out some of the most common ones. If you guys are interested in learning more in depth about these things or perhaps other areas that it may affect, this was recently published in December in a special CF issue of Clinics in Chest Medicine. So I'm happy to provide that resource for you should you want a little heavier reading. So let's start with depression. So interestingly enough, if you think about the symptoms of depression, a lot of them overlap with physical symptoms of CF. So we're talking fatigue, changes in sleep, changes in eating. And so it's really important as a clinician, or if you have a loved one or someone you know and you're concerned about their mood, to really focus on some of the other symptoms in depression that might alert you that something's going on. So is this individual having trouble finding joy in things that they used to love? Is this individual experiencing more guilt and self-doubt, lower self-esteem? And I think it's tricky when we think about suicidal ideation, which is thoughts that you would be better off dead or of hurting yourself in some way, because there are many times I have found in my own research and work that people say, yeah, I really wish I didn't have to deal with this. Yeah, there are some moments when I don't want to deal with this, but it doesn't necessarily mean that they're suicidal. It just means we need to have more conversation. We can't just take things at face value. With the advances in medical discoveries with Trikafta, we are starting to see an increase in mental health symptoms and some reports of that, despite it not being on the side effect label in the phase 3 clinical trials. So that's something we're keeping our eye on. And also with Trikafta, we've seen a baby boom in women with CF. And so that leads to a significant shift of hormonal changes. So we're paying attention to it both during and after pregnancy as well. The next area is generalized anxiety. And so this is a diffuse anxiety across multiple domains. And what's really important here is to have some compassion and realize that people with CF have very rational fears. It's not it doesn't need to be entirely pathologized. They are worried about their disease. They are worried about their life expectancy. Can I have children? Am I going to get on disability? Am I going to lose my disability? How am I going to get insurance? How am I going to pay for all of this stuff? There are lots of very real fears and anxieties. So when we look at generalized anxiety, which is also something we screen for at least once a year, more dialogue. We have to level up. We can't just look at the screener. We have to really assess how much is this impacting somebody's daily functioning, because I was actually just talking with Paula earlier about how anxiety has a function. Anxiety isn't all bad. We're so quick to label it as negative, but having some level of anxiety is actually what gets us to do things, take things seriously, do things we don't want to do. And so it's really finding that balance of how much is their anxiety affecting them. If it's crushing them, if it's paralyzing them, we need to figure out a way to treat that. Related to generalized anxiety, I would say this is sort of a cousin, is procedural anxiety. Procedural anxiety, in a nutshell, is acute distress leading up to a procedure or actually during a procedure. And this tends to manifest differently in kids versus adults. So in kids, we see a lot of the externalizing behaviors. We see a lot of crying, screaming, kicking, resistance. And then on the flip side, with adults, we see a lot more internalizing behavior, like I'm just not going to go to that appointment, or I'm not going to tell anybody I'm feeling sick because I know what happens. I know all the tests that my doctors are going to make me do, so I'm just going to pretend that nothing's happening. So a lot of the children's centers, I think, have done a really nice job addressing procedural anxiety by working with parents and kiddos, using lots of distraction techniques. There's this thing called the buzzy bee. It's like a little bumblebee that vibrates, and the kids will put it in their hand, and it will literally divert their attention to that so that they're not focusing on the shot or the blood draw they're about to get. Videos work great, singing songs works great, and I think one of the number one ways to provide comfort to someone is to ask them, how much do you want to know? Some people like the 3, 2, 1 countdown. Some people are like, no, just do it. And some people are like, I need to know all the information of every single thing that you're doing in order and how long each thing is going to take. And some people are like, just do it. So coming up with that plan is really helpful for somebody as they're going through these complicated medical procedures. And I mean, if you look at how many times people are going to the hospital for CF care visits or for tune-ups, if they're having an exacerbation, they just have an increased likelihood of having procedural anxiety simply because they have an increased likelihood of going to the hospital and having procedures. Next, ADHD, so attention hyperactivity disorder, or attention deficit hyperactivity disorder. So in people with CF, this is 2 to 4 times more common than in the general population, and it's also been reported in parents and siblings. And so some of the hallmark symptoms: disorganization, trouble getting tasks started, trouble remembering things. This can be really challenging when you have a complex medical regimen, both as the caregiver looking after a kiddo and trying to get them to do all the things, or if you yourself have CF and trying to manage all of these things. So when we think about how to treat ADHD, there are plenty of non-medication options that are out there, working with a psychologist, doing different behavioral techniques. However, sometimes medication is the right option. And when we think about introducing stimulants into somebody with CF, that oftentimes will have side effects of decreased appetite, which when we are talking about maintaining a certain level of nutrition, because nutrition has been linked to lung functioning, what ends up happening is it just can make things more complex, because if they're not eating enough, then they might actually increase the likelihood that they're having some sort of exacerbation based on poor nutrition. At our center, our pulmonologists typically don't prescribe stimulants because it's not their wheelhouse, right? And I know that a lot of people go to their center for a one-stop shop. So at our center, we will refer them to a psychiatrist, and we will work with them closely to ensure that we are providing good care, that their nutrition needs are being met, and that everybody's on the same page. Next category, disordered eating. I think this is inherent in this population because from day one, at such a young age, there are a significant amount of nutrition deficiencies, especially if somebody does not have a working pancreas. They have to take enzymes, they have to be hyper-focused on what they're eating. In addition to that, we've got CF-related diabetes where people have to track what they're eating and use insulin. And so there's this hyper-focus around mealtime. And foods become a little scary because you're trying to regulate everything. We're also seeing with Trikafta kind of the flip side of that, where if you ask any adult with CF what their childhood eating patterns were like, chances are they would tell you, my doctor said I could eat whatever I want. I could have a milkshake with every meal. I just need to get those calories in. And so if that's what you've grown up with and that's your routine, starting Trikafta, where you are now able to absorb more of those nutrients, it becomes very challenging to sort of undo a lifetime of routine. So I think it's important to have compassion, and it's not just as simple. I mean, for those of you out there that have ever tried to lose like 5 pounds, it's really hard, right? And so imagine taking a medication where you are now gaining a significant amount of weight and it's healthy for you, but at the same time, there's this conflicted sense of, I don't want to have to buy all new clothes. I don't want to have to deal with this. And so we often will see disordered eating patterns, and that's something to pay attention to. The literature also suggests when we are looking at CF in conjunction with other chronic medical conditions, persons with CF are more likely to use excessive exercise and kind of monkeying around with their enzymes as a way to control their weight. So that's also really important to pay attention to. Not surprisingly, when you look at the next category, this is a respiratory disease. I mean, it's a systemic disease, but primarily respiratory. And so it's pretty common for people to come in and say, I am having tons of trouble with my sleep. So there have been studies done that have shown over half of people with CF report some level of impairment in sleep or their quality of sleep. And we've seen a lot of different sleep changes in response to CFTR modulator use. So these are things like Orkambi, Kalydeco, Symdeko, Trikafta. So it's important to monitor that. And I think a lot of times when people aren't sleeping, they just will do anything to sleep. And so a lot of times they'll go straight to the medication. Medication isn't always an option for somebody, whether it be interactions with other medications that they're taking, or we know with sleeping medications that they can be highly addictive, right? You become just dependent on them. And it can actually reduce respiratory rate. And so that's not good for some folks in this population. The good news that a lot of people don't know, and I hope primary care physicians are actually putting out there more and CF physicians are putting out there more, is about 10 years ago, the American College of Physicians put out a paper and said the number one treatment recommendation for insomnia should be seeking a behavioral sleep medicine specialist to help undergo cognitive behavioral therapy for insomnia. Basically, with sleep, there's something that triggers the insomnia, but then there are factors that perpetuate the insomnia. And so the goal of that type of therapy is to address what are those perpetuating factors? What are those behaviors that are maintaining the insomnia? And this is above and beyond hypnotic sleep medication. So I think it's important to put that out there to people instead of always rushing to the medication. And in fact, a lot of the folks that I work with really like that because they don't want to take any more medication. And I'm fine with that. So now that we know what are the prevalence rates of anxiety and depression, what are some unique symptom manifestations in other areas of mental health, what are we doing? What are we doing to help? Like, thank you for all of this information that may be intuitive, but what are we doing to help this cause? And so the CF Foundation has partnered with Community Voice, and Community Voice is exactly what it sounds like. So to be a part of this, you have to be a person with CF that's 13 years or older or a caregiver of somebody with CF, and you will oftentimes get surveys that ask about different things. You might get asked to be on a working group, sit on a panel. And, the mental health research prioritization survey that Ginger was talking about earlier, this was pushed out to Community Voice so that we could see what is important to people out there. And what I have loved about working in this space is so much of the great research that we do comes from the bottom up. So bottom up means, what does the community want? You tell us, and then we will figure it out and we will answer your questions, as opposed to maybe top down, which is sort of this ivory tower mentality of like, we know what's best and we're going to do these things. So usually it's a little bit a combination of both, but specifically at the foundation, they really value the voice of all of you and individuals with CF. And I love that because I feel like as a researcher myself, I can give the people what they want. I can answer the questions that people have instead of just answering the questions that I have. So there was also a WellMe study done that was in 2022, and it showed that there was, a significant amount of anxiety and depression that people were experiencing. Most of the people, about 80% of the people, were on Trikafta. And so it just, again, it goes along with what Ginger was saying, in that there is an increased desire from the community and from providers to understand what is going on with mental health and modulator use, what is going on with body image and nutrition. Do we need to be addressing medical traumatic stress more? What are these things that matter outside of just the lungs and the gut? So the CF Foundation does a really nice job being able to fund different studies. And so this is just a list of mental health studies that are currently being funded. And I just sort of group these into categories. There are more studies out there, obviously, that the foundation is actually supporting. These are just the ones that have a primary focus is mental health. So we've got sleep. What are some interventions to reduce symptoms? How can we better detect and diagnose things in people? Where can we go in terms of improving things at a systemic level? How do we address caregivers and partners, nutrition, smoke exposure, all of these things? So it's amazing that they're able to fund all these researchers across the country. And some of these grants are a year, some of them are 5 years, some of them are more. Just depends on the level of detail within the grant. How many different sites are they doing? Are they doing something longitudinally? Something new that happened this year is the Mental Health Research Working Group that the foundation created. We call it MERWIG because it's just a mouthful and we love acronyms. I don't know if you've probably seen like a million acronyms and all these other talks. We couldn't come up with a better one, so we were like, let's just call it what it is. And so our mission as a group of different researchers and clinicians across the country. These are amazing minds that have different levels of expertise in different populations, is to advance the knowledge of what we know about mental health in the CF population throughout the lifespan, and to promote clinical and translational research. So that's just a fancy word for connecting kind of bench science like cells and animal models to people, and how do we actually make use of that? So being able to combine all levels of research into one in order to improve understanding, prevention, diagnosis, and treatment of mental health conditions in CF. And so right now, our priorities that we're going to tackle, we're inviting some new members. We had a call for grants, a bunch of people applied, and so we are going to be onboarding some new members. And our priorities are to look at Trikafta and mental health and body changes in nutrition. That doesn't mean that we're not going to study other things. Those are just kind of top of mind, need to get those questions answered. And on our team, we've got basic science researchers. We have people that are involved in genetics. We've got pharmacists. We've got adult psychologists, pediatric psychologists, and then within all of those disciplines, different levels of expertise in mental health. So we've been very mindful to cast a wide net and make sure that we have all these different areas covered so we can look at it from different angles. And that also brings us to you guys in the audience. And so fundraising, outreach, and dialogue is so important. So we need people like you guys to help us make these changes. Fundraising allows the foundation to fund more studies in different areas, right? This stuff doesn't come out of nowhere, right? We have to find ways to get people to see how important this is. And the foundation, they value mental health, as I've demonstrated from the different studies that I've talked about and the prioritization surveys. They are not just focused on physical health. And so when we can get more fundraising going, we can fund different areas outside of just the lung and the gut. Outreach also increases awareness that there is a focus on the mind and the body. And frankly, it just starts normalizing the conversation around mental health. Like, it's 2023. I'm so sick of stigmatization of mental health. I think that what we saw over the past few years with the pandemic is nobody's immune to mental health stuff. I guarantee everybody in this room had a moment of panic during the pandemic. Maybe it didn't last long, maybe it lasted the whole time, maybe you still have it. Nonetheless, we've all experienced some sort of mental health symptom, and so we can't stop saying it's us versus them. It's all of us, and we all need to make sure that we are leveling up and having these conversations with each other and from the CF Care Center level with the people that we serve and we want to support. So as I'm talking about support, I'm going to turn it back over to Paula, who's going to talk about some resources that are available to you or to others with CF that might be more interested in mental health.
Thank you so much. Isn't she great? I hope you recognize why we were thrilled that we were able to invite Dr. Bathgate here to speak to you. Whoop. Okay, what I would like you to do while I'm talking about the resources is to consider the questions that you might want to ask, because we will have a time for question and answer for Dr. Bathgate. And we would appreciate very much if you could use that Hop-In app and you could ask your questions that way. I don't see Christy back there. I don't see any of the, thanks, Molly. I don't see any of the instructions on the table, so I hope that people know how to get into Hop-In. Yes? Good? All right, so you can think about the questions while I'm speaking, and please go ahead and put them in there. So let's talk about the resources that the CF Foundation has for you to access. We do have a mental health advisory committee, as Ginger had mentioned. She's part of that committee, and we work with them. They are experts in this field, and they help us to develop pages on our website, on cff.org. There are pages there about anxiety, generalized anxiety, as well as procedural anxiety, depression, substance misuse, as well as coping while caring for someone with CF. We have handouts there, we have videos on there. I encourage you to access cff.org and learn more. We also have handouts, one-pagers to help individuals with CF and family members work with their care teams in order to have discussions about these issues. We have a list of those handouts and resources there. And I ask that if you see something that you wish was there, that isn't there, please come up and talk to me. You have always been a great resource to us in order to acknowledge the gaps that we have. There was one year, there was discussion about something for siblings. You will now see that we have a handout for siblings. There was another year that there was conversation, and appropriately so, about the frustrations that individuals have when they go to a community mental health provider, and that provider does not know about CF. And so the Mental Health Advisory Committee put together a handout for that community mental health provider called Intro to CF for community providers. And so hopefully that will just help make that first appointment just a little easier, that that individual will know a little bit more about CF. Last year, we were able to highlight the new resource, Finding Mental Health Professional. I had a few of those handouts in the back. And this year, really, truly hot off the presses, like 2 days ago, we have an ADHD handout. And that is also on the back if you would like to take that. I welcome you to take it. take a few with you if you'd like. We understand that community support is also so valuable and important in our mental health and emotional wellness journeys. And so I wanted to highlight some of the community support programs that we have and that for you through the CF Foundation. CF Peer Connect. CF Peer Connect is where a trained peer mentor can be what's the word I'm looking for? Can be matched. That's the word I'm looking for. Can be matched with somebody who says, you know, I'd like to talk about someone who's gone through this life issue. Can you match me with that person? And they've done that. They've done that in the area of transplant, for new parents, for parents of someone going through procedural anxiety. Let's say you have an issue of a life event or going to college, and that there's someone that wants to talk about that. So I encourage you to get involved with CF Peer Connect if that's something that resonates with you. We also know that the community supports one another through our virtual conferences. And so we have those community conferences, BreatheCon, ResearchCon, FamilyCon, as well as Next Breath. It's a way that the community is able to connect with one another. And also CF Foundation Cares events. Some of them took a little hiatus during 2020, but they're coming back. And that is meant to be a time of small group, of community and conversation, and that is supported by the local chapters. If that is something that you are interested in getting involved with, interested in learning more about, I encourage you to contact your ED, contact your chapter, and that would be something that maybe you could help them with. We also know that if someone is going through a time where they cannot access their medications, they have a lot of anxiety about their insurance or housing issues, what have you, that would be very difficult to deal with their anxiety if those needs are not being met. And one way the CF Foundation supports that is through CF Foundation Compass. And if you have not learned about Compass, if you have not accessed Compass, I encourage you to reach out to them when you have a need. That would be some way that they can offer some support to you. And lastly, the impact grants. We have offered grants to many programs, and just last week I heard that there's an impact grant called Brighter Beginnings, and that is for the newly diagnosed family, and it's an educational platform, and it's something that is available to those new families. So those impact grants are really making an impact, and such that's why we call them that. So with that, I'm going to go and sit over there with you, CJ, and we're going to go to a time of question and answer. All right, here we go.
Is anybody else hearing that music? Yeah. I'm like, is this my phone? It's not my phone. It's totally fine if it's somebody's. Just making sure I wasn't hearing anything.
Okay. We did have one question come in. Please keep those questions coming. And the comment actually is about sleep. You spoke about sleep, and this person appreciated CBT for good sleep. But their question is really around the safety of CBD and edibles for sleep versus medication like Ambien. Do you have a comment about that?
So definitely, is this on? Okay, great. So here in Colorado, marijuana is legalized. I think that it's important when we talk to people to meet people where they're at. We much prefer edibles, salves, those things. We don't want anybody smoking any of that. We want to just make sure, though, if you're utilizing something like that, is that your only coping tool for what's going on with sleep? Is that covering up something else that maybe needs to be addressed? And so if the answers to those questions are, that is the only thing that I'm using, I just kind of want to forget whatever just happened, I'm going through a breakup, or I just lost somebody I love, or I'm just really stressed out at school, I think that's even more reason to think about introducing other things into the mix to help you cope. So while we're not entirely against them, literature does support that those things can help with sleep. It doesn't mean that it's always the best option. So it's so important to just individually talk to somebody and figure out what it is that they need. I mean, some people are like, oh, I have a glass of wine before or a beer before bed. Alcohol is a depressant. It's going to help you sleep, get to sleep. But what's going to happen is your body goes through these kind of mini withdrawals throughout the night and you get really broken sleep. So if our sleep starts from light sleep to deep sleep to REM sleep and then repeats that process 4 or 5 times a night, if you are using certain substances, it kind of keeps you in this lighter wave sleep, so you never really feel restored in the morning. So I think, full answer to that question is it's just important to take a step back and ask yourself, why am I using what I'm using? Is there something else going on that would be helpful for me to address? Because a lot of times if you address that underlying component, even if it's just a behavior, even if your behavior is every time I get into bed, I look at my phone, that's something that's a learned behavior. That's something that we as sleep medicine specialists, as psychologists can help you unyoke. So just ask yourself, is there something else that I could be using instead of a substance?
I appreciate that answer, actually. That was very good. Very thorough. I don't see any other questions coming in. So why don't you, we need you to use a mic. So that's okay. I understand. I didn't either, actually, originally. So
My question is, why is ADHD so much more prevalent?
That's not an area of research that I have studied in depth. I can't really answer that. I do have some colleagues, though, that would be able to answer that. I'm not really sure, though. I think that's such a great question, though.
we will have more information about that on the website, hopefully in the coming year. We are working with our other specialists, our other experts in that field. So thank you for the question, because you point out a need that we have and an interest that we have in that area.
And we see a lot of people with it and, figuring out medication or therapy. What do we need to do? They also put out that new resource specifically on ADHD. So the answer might be on that resource for that matter. I haven't had a chance to look at the updated one, though, yet. That's a great question. Thank you.
Come on up here, Margie. Well, our virtual people would like to hear your question. I'm sure it's going to be a great one.
Okay. I'm Margie from Greater New York. Thank you so much for your focus on our community. So my question is, and I know you can't comment because everything's individualized, but do people who have CF and take so many medications benefit the same way the general public can from antidepressants and anti-anxiety medicine?
Yes. The short answer is yes. There are multiple components that go into when you finally get a diagnosis of depression, right? Some of it is genetic, right? We kind of have this, I like to think of it as it's like a loaded cannon. So the cannonballs are what come from our DNA and from our parents. And sometimes the cannonballs just sit there. Sometimes, though, we experience things in our environment that light the fuse and launch the cannon. So some people have just a more kind of genetic vulnerability to it. There are some interactions with antidepressants with some of the modulators, so your pulmonologist can help, or pulmonologist can help work with the individual to make sure they're getting the appropriate dose. But they can absolutely help, because a lot of times it's not just the environment, it is something just that's internal that could use a little bit more serotonin or dopamine or any of these other neurotransmitters that affect our mood. So absolutely. So if you know somebody that has CF and they're really struggling and they've been through therapy, the gold standard is actually a combination of doing a medication and doing therapy, because the medication can sort of get you over the hump. It can take some of the edge off of whatever is happening. And then the therapy can actually address some of the things that no amount of medication is going to get rid of.
We are getting questions online now. Here we go.
Oh, great.
Okay. So, regarding children exhibiting depression and anxiety, what's the youngest age it has manifested once Trikafta was started? And has it got to a point where Trikafta was stopped?
All right, I love this question. So, I am an adult psychologist, so I don't have all the statistics on the pediatric side. But what we know is, so drugs go through these clinical trials and they have different phases. And the last phase, when they tested people across the US that were interested in taking Trikafta and met very specific guidelines, they found that there were no adverse events or serious side effects related to mental health. Now, in order for a side effect to pop up on a drug level or a drug label, it has to be happening in about 5% of the population. So I did some research on our center pre-pandemic, and I looked at discontinuation rates due to a mental health component. And there are a significant amount of people. It's about 3% at our center. So, I mean, it sounds like a small number, but that 3% matters, right? And so just to say, oh, there's no mental health side effects with a modulator, that's what the MERWIG, the Mental Health Research Working Group, that's what we're trying to unpack and uncover, because I know from the adult perspective, we have absolutely had people stop because it was, that risk benefit ratio. They were like, I'm just not having it. Like, this is great for my health, but my mental health, like, I can't go on like this. And we've seen things like mental fogginess. We've seen increased anxiety and depression. There's actually been some research articles that have come out. 2 articles, they actually were all 15-year-olds with suicidal ideation that started when they started Trikafta and then pretty quickly stopped when they stopped the medication. So we're as researchers and clinicians gathering all of this information. Now, in terms of how young does that manifest? Well, I mean, I think that we'll probably be able to answer those questions after we answer the adult population, just because it's a trickle-down effect, right? It was approved in adults first and then had this downward approval rate for younger and younger and younger. But short answer, yes, people have totally discontinued Trikafta, and you ask yourself, like, why? This is this miracle drug. Well, it's not a miracle drug for everyone. And so I think it's important to kind of check our expectations and know that just because somebody's eligible for a medication doesn't mean it's going to work really well for them.
We have a question about, she says, whoever says, in the study that was presented, was patient ethnicity tracked? And if so, does cultural background impact levels of anxiety or negative feelings towards getting therapy?
I don't know if it was tracked either, but I would say that absolutely different environments that we grow up in, different cultures that we grow up in, it does affect one's, I guess, willingness to seek out therapy. And it's not just based on race and ethnicity. It's also, gender identity. It's also just even the family unit that you're in. So there's so many environmental factors to that I don't necessarily know if it was tracked. I mean, I think maybe just like some baseline demographics, but not necessarily the outcomes that person is asking about.
Let's see, there's a question. Are there resources for schools, school counselors to help support our children living with CF in school settings when struggling with anxiety? I often communicate, I often communicate with the counselor, but if there's a specific resource available, that would be phenomenal. I would like to say this is something we're working on. We are working with a group for more resources around school and in this area in particular. It might take a little time until we get them available for you, but we are working on that. Right now, we are kind of doing an environmental scan, see what is out there and seeing what we need to focus on and really make specific for CF. So there will be more to come with that. So thank you for that person who asked that question.
I would also add to just make sure you're an advocate for your kid. There are plenty of opportunities to meet with the school, whether it's a parent-teacher conference. Principals are always available. You can reach out to the school guidance counselor, and also within your local CF center, making friends with the social worker on the team. They are the ones that are going to be doing a lot of the legwork, communicating with the school, trying to get certain accommodations or letting the school know about these things. So use your resources, absolutely. And even though you've brought it up once, it's okay to keep bringing up, right? You can be a nice squeaky wheel. You don't have to be an annoying squeaky wheel.
All right, the next question is, you mentioned suicidal ideation when digging deeper. Have you found that was more so intrusive thoughts or wanting to pause, avoid? And has something like group therapy been studied and found to be helpful?
So with suicidal ideations, I would say the most like I see a lot of people when we are doing the screening, they will endorse, yes, I've had thoughts that I'd be better off dead or hurting myself. But when I probe further, I would say, I mean, if we're talking statistics, maybe like 9.5 times out of 10, it's not this active intent or plan or anything like that. It is somebody that is just exhausted, right? There's just a high level of treatment burden and pressures and just not wanting to deal with things. But just because somebody has those thoughts doesn't, I mean, there's so many levels after that in terms of intensity, intention, setting a plan, how imminent is that risk. And so, I mean, we see it, but it doesn't necessarily mean that it's at an alarming rate. I will say I remember some research that I just read. I think it was from 2020 until today that there were mental health reasons that adults and I guess adolescents with CF attempted suicide. And there is research from the patient registry that has that, but I can't remember the figures right offhand. I don't know if you know either.
The registry numbers are low.
Yeah.
I do know that.
Yeah.
But I don't know what paper
But they
you're
do look at the
discussing.
cause of death, and suicide was definitely in the mix, but yes, at a lower rate.
Do you know if there's anything in regards to male reproductive health anxiety?
Yes. I have seen this clinically. There's actually, the foundation has created a sexual reproductive health working group, and a subset of that working group is specifically on male fertility. I would say from a clinical perspective, there is a lot of anxiety about, am I in that teeny tiny percent that can have a biological child naturally without assisted reproductive therapies? There are fears. I mean, we have seen this a couple times where an individual will be a father and will not have known that they were unable to have children without assisted reproductive therapy, so that can come up. But yeah, there's certainly anxiety. I think we see that in the general population as well. But with all the advances of like in vitro fertilization and all of that, like people with CF, men with CF can absolutely have a biological child. So just to put that out there.
I'm going to open it up to the room since there's nothing online. If you want to come up.
Come on up. It's just a conversation. It's nothing too serious.
Question that just came across.
Yeah.
My son has CF and he'll be a dad in 3 weeks thanks to IVF. So
Congratulations. I love that.
so excited.
And related to that, did you send out the resource? I've been out of office on spring break for the past week, but I did see something come through my inbox that said, I think it's the Gunnar Esiason Foundation.
Yeah, I saw that.
Okay, good.
Yeah.
So the Gunnar Esiason Foundation is now providing couples where one individual has CF some money to help pay for
Right.
IVF. So I don't know if I just like stole your thunder.
Okay. No. I got other thunder.
Okay, all right, bring the thunder.
My other thunder is, what are we doing for the parents of adult children who their whole life has been dedicated to that child, and then they get married, they start, and we know that our whole world has changed because the CF community has been family, and then we're like cut off. And we're like, oh, now I have a great relationship with my son and daughter-in-law, and I poke the bear and go, can I throw me a bone? At least let me go to one clinic a year, that kind of thing. But parents, it is a loss. It's a new dynamic in the empty nest life as well. So
I
are we
agree.
doing anything for the parents?
You know, when we transition folks from pediatric care to adult care, we have a high focus on that, you know, in terms of increasing independence and the person who is seeking care. And also in that increasing independence is also talking with the parent to say, how do you feel about this? How much, and having them have a dialogue about how much do you want this person to be involved? You know, I think that from one of my slides, there are some specific studies that are looking at support for caregivers and partners. I know that there is a CF spouse project. I think what just popped in my head is somebody asked about group therapy before. I think there are different groups that meet. CF Peer Connect. You can connect with other parents that are going through a similar struggle, because I guarantee you're not the only one. And I appreciate your braveness to come up and share that, you know, because it's a new normal. And so if we look at it through the lens of routine, we've all been used to a certain routine. And you can kind of think about this like if you've ever started a new job, right? You know you're qualified, you know you can do it, and you start this new job and you're like, crap, I can't do it. Am I qualified? I don't even know. All it takes, though, is a few weeks, maybe a few months of getting into a routine, and then you're like, I've got this. And so it's creating that new routine with your loved one and getting that rhythm down and starting a new normal. So it's just about creating a new routine. And certainly folks at the Adult Center, wherever you are at, I'm sure they would be more than happy to connect you to different like caregiver things and others out there as well, not just singling you out, of course.
Yeah,
It's important.
I was thinking that maybe some of the chapter staff might like to write that down as an idea for a CF Foundation Cares event. That seems like, and Grampians, right?
Can you say what that program is for people?
Well, I know that there are Grampians at each chapter, that there are a group of, we have our Grampian star over here. I'm going to walk over to you, Bonnie. I know that our videographer doesn't like that too much, but I know Bonnie will have a little trouble.
Thank you, Paula. Well, first, for those of you who don't know, the Grampians program, Grampian stands for Grand Champion, and it's just a program that is within the foundation, and each chapter will soon have a Grampians program in it, and it's where anyone in the family, whether it's a grandparent, an aunt, an uncle, a godparent, friends of the family, they want somewhere to be within the foundation that they're part of their loved one's story. Because so many families have different dynamics, and mom and dad maybe aren't ready to be part of the foundation, or they're not ready for their extended relatives to be part of the story. Well, the foundation is welcoming them in so that they feel comfortable, whether it's to learn more about cystic fibrosis, to connect with other people just like them, or because they want to get involved and help fundraise or help at galas, or we just want everyone to feel that they have a place in this foundation. So that's what a Grampian is. But we were trying to ask a question. Mike was going to go up, so I just had knee surgery, so he didn't want me to go. I'm thrilled to see that there is now resources for ADHD. My question is, we know that the same number of people who live with cystic fibrosis, that same percentage that's in the real world also live on the autism spectrum. Do we have resources, or should we have resources, for our care teams to know how to take care of somebody on the spectrum? We're in a situation where our care team just jumped in and made sure that the endocrinologist and the gastroenterologist and this enterologist and that one all knew that Delaney lives on the spectrum. She's not the easiest of child to care for, but they all took the time to learn how to care for her. But I know there's other care centers that don't have that kind of connection. It is difficult getting them to comply at visits with the things that need to be done. So I just think if it's not available, maybe it could be available to help train their caretakers medically.
I agree. And I think part of the beauty of a multidisciplinary team is that people talk and we all want to provide the best support and the best care for who we're seeing that day. So I'm glad that you have a really great team that is doing that. I think it's a great suggestion to add to the mix as well. We've got kind of these online resources for clinicians and researchers called NACFC 365. It could be something that, as a program planning committee member, I could put out there to have some sort of training on that. I think that's a wonderful idea. And I'm also realizing, in the essence of time, it is lunchtime. So thank you guys for coming. Keep the dialogue open about mental health. It's nothing to be scared of.
Well, I wanted to thank you, CJ. You took place, and thank you all of you. Have a great afternoon.